Thank you for inviting me. Thank you for your presentation. And this is my conflict of interest. And these are the points I like to cover very briefly. And let's start from definitions. In essence, comorbidity is a statistical concept. It refers to the co-occurrence of two diseases in the population at a rate which is higher than expected by chance alone. And this definition allows to separate comorbidity from the simple co-occurrence of two conditions as expected by chance. Basically, there are two different modalities which can be involved in the statistical association. Either one disease is the cause of the other one, and many times we refer to such a situation with the term of complication, or on the other hand, the two diseases may share a common risk factor, such as for basal cell carcinoma and melanoma. And in many situations, there is a sort of combination of these two modalities. Let's move to psoriasis. And we know that psoriasis is associated with several extracutaneous pathological conditions, and it is considered nowadays as a systemic disorder. I will focus a little bit on metabolic syndrome. The statistical association of psoriasis with single components of the metabolic syndrome, such as diabetes, and with the consequences of the metabolic syndrome, such as cardiovascular disease and non-alcoholic fatty liver disorder, is well documented. And here are summarized the association in terms of the ratio or in rates. And the statistical association may at least partly be explained by this association with smoking and body mass index. We know that obesity and smoking influence the development of psoriasis, and these factors are more prevalent among psoriatic patients as compared with the general population. But another possible non-exclusive explanation is the potential effect of chronic inflammation, particularly inflammation originating from epithelial tissues on the metabolic compartment. There are a number of cytokines which can be produced in psoriasis that could affect single components of the metabolic syndrome, as just summarized in this picture. Interesting, even a localized inflammatory condition such as periodontal disease has a documented association with cardiovascular diseases. And it is of note that recently parodontitis has been associated with psoriasis. We cannot make any direct inference from this as observation, but it is worth noting them. Let's move to consider the consequences of recognizing psoriasis as a systemic disease. Several recent consensus documents and the guidelines has been delivered focusing on comorbidity screening and management in psoriasis. What these documents lack, in my opinion, is a clear statement about the responsibility of dermatologists with respect to the management of comorbidities in a way similar to this document in rheumatology, where it stated that the rheumatology is responsible for CVD risk management in patients with rheumatoid arthritis and other inflammatory disease. Let's say overweight and obesity are, in my opinion, particularly worth of consideration. Obesity plays a key role among modifiable risk factor for psoriasis, and it is an important component of the metabolic syndrome. It also affects the risk of developing arthritis. Obesity seems to influence disease severity as documented in this survey, and it influences treatment response irrespectively on the drug being prescribed, as documented in this study from the SoCare registry in Italy. And also it has an impact on the treatment discontinuation due to lack of efficacy or side effect, as documented in this BioBioderm study. Finally, But it is particularly important to consider obesity in childhood and early adulthood, since it has been documented that obesity in early adulthood is a risk factor for developing later psoriatic arthritis. So we are facing a worldwide epidemics of overweight and obesity, and the WHO has launched a global strategy to prevent obesity, with these points being mentioned here. Years ago, we did a trial in overweight and obese psoriatic patients who were starting a new systemic treatment for their disease and randomized them to receive concurrently with the new medication either a structured intervention with diet and promotion of physical exercise to reduce weight, or simple information on the importance of weight loss. And there was a significant decrease in weight in people on the active intervention, paralleled by a better improvement in PASI score compared with the control group. A recent systematic review confirmed that a dietary intervention may reduce the severity of psoriasis, even if, to my disappointment, I must say, the evidence was considered as of rather low quality. As a matter of fact, dermatologists are reluctant, or seems to be reluctant, to be involved in educational intervention, as documented in this survey from the United Kingdom. They are much more attracted by the possibility of modulating risk through pharmacological intervention. And it has been documented that treatment by a biological agent and methotrexate may reduce, in fact, cardiovascular-related mortality as compared with other therapy. And these data fit with the proposed impact of epithelial inflammation on the metabolic syndrome. I don't think that these data are, let's say, contradict the possibility of an additional intervention on obesity and weight loss. What about the future? In my opinion, there is a need to develop research programs on comorbidity and to improve the proficiency of dermatologists in the area of health promotion, health education, following the model, for example, proposed by the CDC with the healthy schools. And dermatologists should improve their communicational skill and be familiar with scientific approaches in the area of education, health education. Not different from therapeutic intervention, health education should be monitored according to a treat-to-target approach, modulating activities based on their ability to achieve results in a given time frame. A complementary issue is the one of patient empowerment. I have not enough time to discuss in depth this point, but I think it's important to also improve patient education. And I'm going to conclude. In summary, I will say that I've lost a slide, but I'm going to conclude. In summary, comorbidity is a statistical concept with relevant implication, clinical implication. Psoriasis has been linked with several comorbidities, which can make disease management more complex and challenging. And in my opinion, it is worth that dermatologists take some responsibility with managing comorbidities. Thank you for your attention.
Thank you so much, Luigi, for this great talk. I can't see some questions in the chat space. I have one for you. You mentioned the complementarity of an active anti-psoriatic treatment to improve the skin conditions, and in parallel, eventually the cortege of comorbidities, especially the cardiovascular risk. In practice, two sub-questions. Do you think that all, especially the targeted treatment, but all anti-psoriatic treatment regarding this risk reduction are the same? That's first, meaning that when we improve the skin inflammation, we improve the cardiovascular, we decrease the cardiovascular risk, we improve the subclinical systemic inflammation in all these patients the same way. That's one. And second, when you have external intervention, when do you promote that? Do you do that right away from the very beginning of the treatment, or do you wait that the patient is relieved from the skin symptoms to address this additional burden? So two questions.
Thank you for your questions. Well, first question, I think that there are documentation of the impact of systemic treatment on the metabolic component only for methotrexate and mainly anti-TNF inhibitors. These are the main drugs which has been studied in, let's say, in observational studies. There are no real randomized trial documenting any impact long term. And so I think these are the two possible ways to go when deciding about a treatment and considering comorbidities. And I think that the intervention should be very, let's say, should start very early in the patient management. I'm not speaking about treatment. I'm speaking about patient management. Even a patient with mild psoriasis who is overweight or obese need education. I think that is something which is in combination with the treatment and maybe also precede the systemic treatment. Is something, and it doesn't take a long. I mean, there is a need to evaluate different strategies. Is an area very open to new ideas to study in a randomized trial. And so we are only at the beginning of that, but there is a need also to motivate dermatologists who care for psoriasis, those who are, as Peter said, psoriasis enthusiastic to consider seriously the health education of patients, because also at least 30% of patients with psoriasis are overweight or obese. I see there is another question here. Routine screening for metabolic syndrome is recommended starting from which age? Is it difficult to do in infants or young? I don't think it's difficult. I think it's the right time to start also educating parents, not only, of course, the child is not educated by himself, cannot be educated directly. I think that there is a need to educate parents and then educate the child. And so as soon as possible, I would say.
Yeah, so in a chronic disease, therapeutic education and disease education at large is crucial, which means probably, like you said, you suggest also some transdisciplinary and different expertise in the same outpatient clinic, which is not always easy to gather. So we can discuss again this issue at the end of the webinar.